Gastrointestinal lower digestive tract disorders. Obesity is defined as a body mass index or BMI of 30 kilograms per squared meter or more. Bariatric is the medical specialty that treats obesity. Surgical treatment might be recommended for patients who are chronically morbidly obese despite conservative treatments. These surgical procedures are either malabsorptive, which will bypass a portion of the small intestine to help reduce food absorption, or restrictive, which reduces the stomach's size. A vagal stimulator, in this procedure, electrodes are implanted per laparoscope that stimulates the vagal nerve and blocks feelings of hunger. Nursing care. During assessment, you may need to ask the patient to lean forward or lie on their left side to help you facilitate auscultation of the heart, lung, and bowel sounds. Otherwise, complete a normal assessment and inquire about stressors, coping strategies, and support systems. Following surgery, be sure you focus on deep breathing and coughing exercises for lung expansion. Anesthesia lingers in adipose tissue, so it can prolong sedative effects, so be aware of this. Pay close attention to skin folds and monitor for skin breakdown. This population is at greater risk for pressure injury due to poor circulation of adipose tissue. Early ambulation is recommended. Imaging studies should be completed to assure there's no leaks in the surgical sites prior to feeding these patients. Dumping syndrome is a common problem with bariatric surgery, and this occurs when food enters the small intestine too rapidly, and it can be accompanied by abdominal cramping and diarrhea about 10 to 30 minutes after eating on average. This population also requires counseling to help assist with negative emotions and negative behaviors such as overeating. These patients are instructed to take supplements, eat diets high in protein, low in fat, carbohydrates, and roughage, and 4 to 6 small meals, and don't drink fluids with meals. This is a mnemonic for the dumping syndrome. Malabsorption describes the condition in which one or more nutrients are not digested or absorbed. It may be caused by bacteria, bile salt or digestive enzyme deficiency, intestinal mucosa alterations, and absence of all or part of the stomach or intestines. Two examples of malabsorption are sprue and lactase deficiency. Sprue types are celiac and tropical. Celiac is a genetic abnormality in which there are several changes or severe changes in the intestinal mucosa and impaired absorption of most nutrients. With tropical sprue, this is caused by an infectious agent resulting in malabsorption of fats, folic acid, and vitamin B12. Lactase deficiency patients don't have adequate lactase to help metabolize lactose. This is also called lactose intolerance. Causes can include inflammatory bowel disease, gastroenteritis, and sprue syndrome. Symptoms can include steatorrhea, or the presence of excessive fat in the stool with large, bulky, foamy, and foul-smelling stools, weight loss, fatigue, decreased libido, easy bruising, edema, anemia, and bone pain. Additional symptoms with lactose intolerance will include bloating, cramping, abdominal cramps, and diarrhea. Diagnosis for sprue is done with lab studies, endoscopy with biopsy, and imaging procedures. Diagnosis for lactase deficiency includes the lactose tolerance test, breath test for abnormal hydrogen levels, and biopsy of intestinal mucosa. Sprue is treated with a diet that avoids foods that aggravate the disease and drug therapy such as corticosteroids, antibiotics, oral folate, and vitamin B12 injections. Lactase deficiency is treated by eliminating milk and milk products from the diet, or by ingesting milk products that have the lactase enzyme added. Supplemental calcium, vitamin D, and riboflavin may also be required. Diarrhea is the passage of loose liquid stools with an increased frequency. It's frequently accompanied by abdominal cramps and pain and a feeling of bowel urgency. It can be caused by spoiled foods, allergies, infections, diverticulosis, malabsorption, cancer, stress, fecal impactions, tube feedings, and medications. Complications are more likely to occur in the very young or the very old and those patients that are in poor health. Complications can include dehydration, electrolyte imbalances, and metabolic acidosis. Chronic diarrhea can lead to malnutrition and anemia. We treat diarrhea with rest of the digestive tract, antidiarrheal drugs, a clear liquid diet or NPO status, IV fluids, TPN, and we have a slow return to a regular diet, beginning with full liquids and then bland foods. Nursing care, be sure that you assess skin turgor and encourage fluids, and monitor skin integrity and treat as necessary. Bedside commode may be beneficial also. Bowel movement frequency will vary among individuals and can be 2 or more times a day or might be once a week. If the stool is soft and passed easily, there's no constipation regardless of how frequently they go. Constipation is defined as being dry, hard, and infrequent stools that are passed with difficulty. It's caused by frequently ignoring the urge to defecate, a frequent use of laxatives or enemas, inactivity, inadequate food intake, a diet that's low in fiber and high in foods that promote constipation, drugs that slow intestinal motility, medical conditions, and abdominal surgery. Complications. The Valsalva maneuver can cause complication in cardiac patients, can cause hemorrhoids and fecal impaction. We treat it with laxatives, suppositories, enemas, stool softeners, bulk forming agents, and adequate fluid intake. A megacolon is a condition in which the large intestine will lose its ability to contract effectively enough to help propel the fecal mass toward the rectum, and it may require regular enemas for elimination and/or bowel training. Make certain that you educate the patient on diet and fluid intake, activity, prompt use of the toilet, using a footstool if the toilet's too high, appropriate use of laxatives and enemas and the consequences of abuse of these. Severe constipation might require repeated enemas and laxatives for relief. And make sure that you monitor for fecal impaction if there's no stool or there are frequent small diarrhea stools. If a fecal impaction is determined, it may require a mineral oil enema followed by a soap suds enema and/or manual extraction. Intestinal obstruction is simply a blockage in the intestines that does not allow digestive contents to progress. It can be caused by a strangulated hernia, tumor, paralytic ileus, stricture, volvulus, which is a twisting of the bowel, intussusception, where the bowel actually shrinks on itself like a telescope, and postoperative adhesions. Symptoms can be acute if the blockage is in the proximal portion of the small intestine. You may see vomiting that may be projectile. It would begin with gastric contents and then bile and then fecal matter. Abdominal pain, constipation, rectal passage of blood or purulent drainage, and abdominal distension. Gangrene can be a complication when there is impaired intestinal blood flow. We might also see a bowel perforation. Shock and death can occur if it's left untreated. Lab studies and imaging procedures along with a patient history and examination are used to diagnose bowel obstruction. And we treat it with gastric decompression with a nasogastric tube, intravenous fluids, and surgical intervention. Make sure that you take vital signs to help detect signs of infection, such as fever and tachycardia, impending shock, which would be tachycardia and hypotension, and examine the abdomen to include auscultation, palpitation, and observation for distension. Another mnemonic for you to help you with bowel obstruction. Appendicitis is the inflammation of the blind pouch that is located in the cecum when it becomes blocked by feces, tumors, helminths, which are parasitic worms, or indigestible substances. The tissue then becomes infected and blood supply can be impaired, pus will accumulate. All of these things can lead to rupture of the appendix. Early detection of these symptoms and determination of the cause of the symptoms can help allow for treatment to avoid rupture. Symptoms can include pain in the epigastric region or the umbilicus that will then shift to the right lower quadrant at what is called McBurney's point. We can also see the low-grade temperature, nausea, vomiting, hip flexion with increased pain if the legs are straightened, severe abdominal distension, elevated white blood cells, absence of bowel sounds, tachycardia, nausea, vomiting, and a rigid abdomen if peritonitis develops. Classic symptoms and white blood cells at 10 to 15 are what help with the diagnoses. We treat it by keeping the patient NPO. We can use a cold pack to help with pain. Surgical removal is definitely necessary, along with IV fluids, and if the appendix itself ruptures, then the patient will definitely be on antibiotics. Make sure that these patients are turned, coughed, and deep breathed, and show them how to splint the incision when they cough. Peritonitis is the inflammation of the peritoneum caused by chemical or bacterial contamination of the peritoneal cavity. Chemical contamination can follow rupture of a digestive tract structure, including the appendix. Bacterial contamination might be caused by rupture of a digestive tract structure or fallopian tube or from non-sterile traumatic wounds. This can cause the body to attempt to wall off the injured area to help contain the injury. Fluid will then shift into the peritoneal cavity and peristalsis will slow or stop. Complications would include abscesses, adhesions, septicemia, hypovolemic shock, paralytic ileus, and organ failure. Symptoms include pain, a rebound tenderness, abdominal rigidity and distension, fever, tachycardia, tachypnea, nausea, and vomiting. The older patient may have more subtle symptoms with less pain and the absence of the abdominal rigidity. Diagnosis is done through blood work to include a CBC and electrolytes, imaging procedures, and/or a paracentesis. We treat it with gastric decompression with the nasogastric tube, intravenous fluids, antibiotics, analgesics, surgery to repair any ruptures and removal of debris. Nursing care would include making certain that you're monitoring cardiac status and monitoring the patient for shock. A hernia exists when there's a weakness in the abdominal muscles that allows a portion of the intestines to bulge through. Most common areas are the umbilicus, the inguinal area, and areas of surgical incisions. However, it's not uncommon to see hernias in the scrotal sac. Hernias can be reducible or irreducible. A reducible hernia will slip back into the abdominal cavity with gentle pressure or when the patient lies on his or her back. When the hernia cannot be manipulated back into place, it's said to be irreducible or incarcerated. Irreducible hernias may have impaired blood flow, which can lead to gangrene, and that becomes a medical emergency. Symptoms: you will see a smooth lump on the abdomen that can disappear when lying down and appears with standing or straining with heavy lifting or coughing. They may have pain with incarceration, and that can lead to distension, vomiting, and cramps. We diagnose it on the health history and physical examination. Treatment: surgical repair or a truss. A truss is a pad and a belt that will actually provide support for the weak muscles and help keep a hernia reduced. Make sure that if the patient is wearing a truss that you examine the skin underneath it and monitor for signs of hernia strangulation. Postoperatively, don't encourage these patients to cough or strain. Make sure that you're monitoring eyes and nose. Scrotal support might be necessary for men, ice packs, and refraining from exertion and or lifting for up to 6 weeks is recommended. Inflammatory bowel disease refers to ulcerative colitis and Crohn's disease, which is also known as regional enteritis, in which inflammation and ulceration of the lining of the intestinal tract occurs. With ulcerative colitis, the inflammation typically begins in the rectum and gradually extends up the bowel toward the cecum. The progression of Crohn's disease is different in that it affects any area of the gastrointestinal tract. Attacks can be isolated and few or frequent and lasting days or months. Causes are unknown, but it can include infectious agents, autoimmune reactions, allergies, genetics, and foreign substances. Symptoms are going to be dependent on the extent of the disease. With ulcerative colitis, we see constipation, diarrhea with bloody stools, abdominal cramping, fever, and weight loss. With Crohn's disease, we see the nausea, vomiting, pain, cramping, rectal bleeding, diarrhea, fever. We may also see night sweats, malaise, and joint pain if there's systemic issues. Complications would be hemorrhage, obstruction, abscesses, fistulas, megacolon, an increased risk of cancer, joint and eye inflammation, skin lesions, urinary stones, liver disease, malnutrition, anemia, fluid and electrolyte imbalances. We diagnose these diseases with imaging procedures: colonoscopy with biopsy, barium enema with air contrast, cell studies, and a video capsule. Drug therapy such as corticosteroids, immunosuppressants, antidiarrheal agents, anticholinergics, antibiotics, aminosalicylates, iron and vitamin B12 supplements, and antidepressants may be given. We may encourage a low roughage diet without milk products. IV fluids or TPN might be needed to help provide fluid, electrolytes, and nutrients. And surgery, which for ulcerative colitis can be curative. However, with Crohn's disease, we may see a recurrence. Be sure that you inspect the skin for impairment, assess for hydration and stress management, and also encourage fluids with these patients. Diverticulosis is characterized by multiple small sac-like pouches in the intestinal wall that occur in weak areas of the intestinal wall and allow areas of the mucous membrane to herniate outward. It's usually found in the sigmoid colon. Risk factors would include a lack of dietary residue, older age, constipation, obesity, and emotional tension. Symptoms: these patients are frequently asymptomatic, but we may also see a change in bowel habits, rectal bleeding, pain, nausea and vomiting, and urinary problems. Complications can occur through inflammation or infection let's try that again. Complications may be seen with inflammation or infection when a diverticulate is filled with intestinal contents. intolerance of irritating foods, alcohol, chronic constipation or persistent coughing, fever, obstruction, perforation, peritonitis, or fistula formation. We diagnose it through occult blood testing of the stool. We can also do an abdominal CT scan or barium enema. We treat these patients with a high residue diet, non-spicy diet, stool softeners or bulking agents, antidiarrheal drugs, analgesics, antibiotics, anticholinergics, bed rest, NPO status, IV fluids, and gastric decompression along with surgery. Make sure you monitor these patients for signs of perforation and provide plenty of patient education. Colorectal cancer is the third most common cancer that most commonly occurs in the rectum or lower sigmoid colon. Patients at an increased risk for colorectal cancer include a history of the irritable bowel disease, family history, or history of multiple intestinal polyps, high fat, low fiber diets with inadequate food and vegetable intake. Symptoms are going to be dependent on cancer location, but may include cramping or pain, anemia, fatigue, weakness, diarrhea or constipation, blood in the stool, narrow stools, feeling of fullness or pressure in the abdomen or rectum, and obstruction. We treat it surgically to remove the cancer itself. Chemotherapy and radiation might also be used. Make certain these patients are receiving plenty of emotional support and patient teaching. Polyps are small growths in the intestine that are usually benign but can become malignant. There are two inherited syndromes, familial polyposis and Gardner syndrome. These have multiple polyps that almost always lead to cancer. Usually they're asymptomatic and they're only found on routine testing. Complications can be bleeding and obstruction. They're diagnosed by barium enema or endoscopic exam with biopsies. Treatment involves a colectomy for familial polyposis or the Gardner syndrome because of the high risk of malignancy. Hemorrhoids are dilated veins in the rectum, and these can be internal or external. In other words, you might see them or you might not see them. If blood clots form, the hemorrhoid is said to be thrombosed. It will be inflamed and be very painful. Risk factors include increased pressure in the rectal vessels from constipation, pregnancy, prolonged sitting, or standing. We may see rectal pain, itching, bleeding with defecation. We diagnose by visual inspection. Treatment will include topical medications, sitz baths, heat or cold applications, a hemorrhoidectomy, which can be done through ligation, sclerotherapy, thermocoagulation, and electrocoagulation, and laser surgery. Make certain that you observe these patients for bleeding and drainage. Provide patient education on constipation prevention. An anorectal abscess is an infection of the tissue around the rectum itself. Symptoms will include rectal pain, swelling, redness, tenderness, diarrhea, bleeding, itching, and exudate. We treat it with antibiotics. We can do a surgical incision and drainage, apply ice packs, do sitz baths, and apply topical agents. Patient teaching is required on proper cleansing following bowel movements. We need to encourage fluids and a high fiber diet for these patients. An anal fissure is a laceration between the anal canal and the perianal skin. It may be related to constipation, diarrhea, Crohn's disease, tuberculosis, leukemia, trauma, or childbirth. Symptoms will include pain before and after defecation and bleeding on the stool or tissue, pruritus, urinary frequency or retention, and dysuria. Usually these fissures will heal spontaneously, but they can become chronic. Conservative treatment would involve sitz baths, stool softeners, and analgesics. However, surgical excision might be necessary. An anal fistula is an abnormal opening between the anal canal and perianal skin. It develops from anorectal or anorectal rectal abscesses, or there can be related to inflammatory bowel disease or tuberculosis. The patient typically complains of pruritus and discharge. Again, we treat these with sitz baths, surgical treatment, which can involve the excision of the fistula and the surrounding tissue, and sometimes the placement of a temporary colostomy. And this will help allow the surgical site to heal. Postoperatively, we provide analgesics and sitz baths for pain. A pilonidal cyst is usually located in the sacrococcygeal area. This will result from a folding of the skin that will actually cause a sinus, which will be easily infected because of its closeness to the anus. And frequently, these cysts will contain hair or skin debris. So honestly, you will see it more often in people who are very hairy. Once infected, it is painful and swollen and can form an abscess. Surgical excision is usually recommended, and the care will be similar to that for the patient who has a hemorrhoidectomy.